Hi, my name's Sierra Wells, and today we'll be talking about Stevens-Johnson syndrome and secondary complications. I chose this diagnosis because it's something that you don't really see often, and I didn't really know anything about it personally before I had this patient, but it can definitely be a learning experience and something to use once we graduate and are working in our own clinics. So for the introduction, my patient was a 42-year-old female. She seemed relatively healthy and she was admitted to the acute setting for an adverse reaction, and I actually saw her in an inpatient rehab following her acute stay. I'm just really thankful that she wanted people to learn from this experience and was willing to let me use her for this presentation. So, Stevens-Johnson syndrome is a rare, serious disorder of the skin and mucous membranes. It's usually a reaction to medication that begins with flu-like symptoms and eventually advances to rashes and blisters on the skin. And it's a medical emergency that involves hospitalization. It can really be life-threatening depending on when you catch it and what causes it. So it's really important to know the signs and symptoms and just be aware of your patients and how they feel. So the early signs of Stevens-Johnson syndrome are fever, sore mouth, throat, fatigue, and burning or dry eyes. And within a few days, it kind of progresses to unexplained widespread skin pain, a rash that spreads, blisters, and then shedding of the skin. And these pictures here kind of show the early, middle, and end stages that you see with this. So some of the causes of this, the most common one is allergic reaction to medication. I won't go through all of the different types, but you see this most common, and this is what the patient I had ended up having it from. But down below you can see that there is an increased risk if the patient has HIV, cancer, or a personal or family history of this. Here are some of the complications that you can have with Stevens-Johnson syndrome. They go from mild dehydration to death, so it is a serious issue that you want to notify a doctor immediately if something doesn't feel right, especially after starting a new medication. So Stevens-Johnson syndrome is an autoimmune cascade. It's secondary to the host's inability to detoxify the culprit drug or new medication that the patient started, and this eventually leads to cell-mediated immune response. The onset of this usually occurs 1 to 3 weeks after the ingestion of the medication, and it's preceded by nonspecific prodromal symptoms followed by skin and mucosal lesions. This syndrome does affect all ages and races. It's commonly seen more in women and increasing incidence with age. Although you can get it if you're an infant or young children, it's very common. But you'll want to have a rapid identification and withdrawal of the offending drug, and usually patients are transferred to a burn unit with aggressive supportive care, and this is the most critical steps in the management of this disease, and long-term follow-ups to make sure that they lessen secondary complications is also very important. Here's all of the stages of Stevens-Johnson syndrome, kind of the anatomical and the physiological response. So I really like this chart because it's very thorough and breaks down the different steps and symptoms that a patient might see and compares them with what they're going through. The next two slides just kind of show pictures of how a patient might present as they're admitted on the acute setting. You can kind of see the blisters on the skin and mucous membranes here. So my patient was a 42-year-old female. She lived in a split-level house with her boyfriend, son, and daughter, and she had 10 stairs with a handrail. And she was an owner of a local restaurant, and she said that they have the best Philly cheesesteaks in town. And prior to her hospital stay, she was independent with no assisted device. Her medical history, she was recently diagnosed with rheumatoid arthritis 6 months ago. She has a history of hypertension, hyperthyroidism, tobacco abuse, and GERD. She's had a surgical history of a thyroidectomy and ORIF 2 years ago, two C-sections, and then she recently had a bilateral amniotic membrane graft of the eyes due to Stevens-Johnson syndrome complications. So for social habits and family history, my patient was a smoker and she casually drinks during the week. She doesn't regularly exercise, but she does stay relatively active with her busy schedule. She has no significant family history related to current condition, but both of the patient's parents are still alive, and her mother has a 20 history of RA, and then her father had a myocardial infarction at age 67, and all of her children and pets are healthy. This was a list of the patient's current medications when she was admitted to the hospital. I won't go through all of them, but I have all of them listed with her daily doses and then adverse effects of each one. At the bottom here with the asterisk, you will see sulfasalazine, which I will talk about because this is the drug that led to her reaction and when she was diagnosed with Stevens-Johnson syndrome. This is a sulfa drug that is commonly prescribed for rheumatoid arthritis. This is just a list of her current known allergies. She wasn't aware that she would have an adverse reaction to the sulfasalazine that she was prescribed. So, kind of a patient background story. The patient was diagnosed with RA 6 months prior to this and prescribed sulfasalazine. She started taking it and had no physical changes. She reports that she didn't feel good from the inside out, but nothing was visibly wrong with her. After taking it, 5 days later, she went to the ER and had imaging and blood work done. Everything looked normal, and she was sent home and told to monitor her symptoms. The next couple days, she started to have swelling of the lower lip and nausea, vomiting, and fatigue, and she got to the point where she was crawling up her stairs in her home because she was so tired. And she ended up stopping sulfasalazine because she kind of thought there was a connection. So the patient was finally admitted to the hospital 9 days after starting the sulfa drug. She then had rashes and blisters on her chest, arms, legs, and feet. She also had shortness of breath, and the burn team was consulted and diagnosed her with Stevens-Johnson syndrome. She went into acute respiratory distress a few days later and was sedated and intubated. She also had a trig placement 16 days after starting the sulfa drug and was diagnosed with pneumonia. She had multiple Procara placements in her eyes and then many skin grafts all over her arms, legs, and trunk. And then 30 days later, after she started the drug, she was admitted to rehab and considered medically stable and on room air when I got to work with her. Here's just a list of the acute problems she had after being diagnosed with Stevens-Johnson syndrome. Acute respiratory failure was the big one, but everything else we kind of had to monitor and keep an eye on during our treatment and progression of therapy. And here's just a list of other healthcare providers that were on our team. These are all the people we communicated with and saw her on a day-to-day basis. For her systems review and integumentary, she obviously had burns and blisters on her chest, arms, legs, and feet. For cardiovascular, she had hypertension, but it was well controlled. And for GI, she reported occasional GERD. Genitourinary, she denies any problems. Musculoskeletal, she had a limitation of motion and weakness, with her left lower extremity being more affected than the right. And then neuromuscular, she just had numbness and tingling in both of her feet that she reported. So this is the patient's pain diagram and rating scale. I'm not sure if you can see it that well in the picture, but it's a combination of aching, burning, and numbness type of pain all throughout her body. Her worst pain she reported was in her eyes due just from the swelling and inflammation, and it remained constant. She reports achy pains in her bilateral shoulders and hands, and her lower extremity pain increases with activity. She describes the pain and feeling not right from the inside out a lot of the times, and then her pain in knees and feet is numbness and tingling, and she describes it throughout the whole leg and feet, no specific dermatomal pattern. Her current pain level was a 7 in the initial eval, and at best she rated it a 3 out of 10, and at worst an 8 out of 10. Some of her aggravating factors for pain were any movement or pressure, and then sometimes bed rest led to muscle cramps whenever she would get up and move or if she wasn't active. And some of her easing factors, she reported that repositioning with pillows and stretching would decrease pain and tightness. And her sleep was disturbed by pain and unable to get comfortable at night. So some of our possible differential diagnoses at this point are TIN, which is basically the same disease as Stevens-Johnson syndrome, but it's more severe in clinical presentation and has more widespread involvement. Another thing is toxic shock syndrome, and that has the fever, hypotension, diffuse sunburn, like erythema, and then it involves three organ systems, so that was another big considering one. And then we also thought Stevens-Johnson syndrome. Since we were on the rehab unit when we saw her, we already had the diagnosis, but kind of going through the process, these are kind of the things that we also thought would have similar presentations. So for her initial evaluation, some tested measures that I chose to do were range of motion, just because she'd had prolonged bed rest and she wasn't moving her body as well as she would be normally. So we kind of went through that, and her upper extremity was pretty normal because she kind of kept active in bed, reaching for things. But her knee and ankle range of motion was kind of limited just because of the bed rest, and we hadn't been ambulating much while she was sedated. So right here you can kind of see the numbers for active and passive, and then the asterisk indicates that it was possibly limited due to pain, and then the blistering and skin grafts. Here are the scores for her manual muscle test. OT really stuck with upper extremity, and PT stuck with lower extremity at my inpatient rehab. So these were the findings from all of the lower extremity muscle test, and then you can see that on the left towards the ankle and foot, that strength testing provoked more pain, but the results kind of helped us guide our treatment and determine what was weak and what we need to work on to improve our patient and get her more independent. Some other tests I decided to do were balance test and just functional mobility. For her Romberg, she only scored 1 second each lower extremity, and her tug was 16 seconds, which is a super high fall risk, especially for her young age. And her Berg balance score was a 39, which put her at a medium fall risk. So these were big areas that we could focus on in trying to get her to return to home safely. She also required mid to mod assist for most bed mobility and transfers, but she was able to ambulate 125 feet with a rolled walker and mod assist just for balance and verbal cues. I did do some neuro testing just to rule out anything, because she did say she had numbness and tingling on her feet, and we didn't want to miss any new symptoms. So she was oriented times 4. She just had a min cognitive delay, which is understandable considering how long her hospital stay was and the progression of the syndrome. But she had normal coordination and diadyskinesia. And then her vital signs all looked very good and were monitored throughout treatment sessions. The final diagnosis of this patient was that she had impaired skin integrity, muscle performance, and range of motion associated with a connective tissue and autoimmune disorder. Her medical diagnosis was Stevens-Johnson syndrome, and the physical therapy diagnosis were decreased right lower extremity and lower extremity strength, range of motion, and overall endurance and balance secondary to her acute course of Stevens-Johnson syndrome. And then the ICD-10 codes are listed below. Her prognosis was really good. She had possible limitations secondary to comorbidities and severity effects, but she's fairly young and had a good support system at home. She was motivated, and most people with Stevens-Johnson syndrome, if they catch it early enough and survive, they have a really good prognosis. These were some of her short-term and long-term goals. We really communicated with the patient to determine what she wanted to get back to doing and help get her as independent as possible. So you can see a lot of our goals are functional to allow more independence for the patient. For Stevens-Johnson syndrome, a standardized management approach is not clear based on current data. Decisions regarding treatment should be made on a case-by-case basis. So I took a multi-system approach since our patient had prolonged bed rest and inactivity following her illness. She required a program that includes stretching of the lower extremity and trunk for postural alignment and mobility, strengthening exercises to improve motor performance, and dynamic function, functional balance, and activities to improve the ability to perform ADL safely. So for range of motion, we really went off considering Kolbe's interventions. We started with passive range of motion exercises just to kind of get postural alignment that we needed for our functional activities. And then we progressed to active range of motion, reps that she could do herself and at home, such as hamstring stretch, hip flexor and quad stretch, and gastroc stretch with a towel. And then eventually we moved to active range of motion, 10 to 20 reps on each lower extremity to help build strength that we need for these functional activities. For strength, we kind of went off range of motion, those postural exercises, and advancing them to TheraBand exercises for lower extremity strengthening. And then eventually we moved on to coordinated exercises and then more functional endurance activities that she'll actually use once she is discharged home to improve safety. Another big area that we focused on was balance, and then range of motion and strength kind of went all together with that to improve to her home environment. We started with static balance and then moved to dynamic, more moving surfaces, transitional activities that you use on a day-to-day basis. And then we also kind of included sensory organization and reduced cues and input so she could learn these things on her own and incorporate more functional activities with dual task and multitasking, and eventually gait and locomotion. So the results of this case study, she was seen for a total of 2 weeks for 90 minutes of physical therapy each day. All her short-term and long-term goals were met, which was super exciting. She did so awesome, and she was able to complete all ADLs, transfers, and ambulation independently with no assistive device and safely. So she stated that she had improved balance, strength, and endurance just from the past 2 weeks of physical therapy. At the time of discharge, our patient was ambulating 600 feet independently. Her lower extremity range of motion improved and met the requirements needed for normal gait, and all of her manual muscle tests were 4 out of 5 in all planes, which is so awesome. Her Romberg improved to 30 seconds on each lower extremity. Her tug score was 9.63, and her Berg balance scale was 56, which are both no fall risk, which was the main goal that we wanted for our therapy interventions. So for the discussion, Stevens-Johnson syndrome is a rare emergency disorder of skin and mucous membranes that occurs secondary to use of certain drugs and infections. The effects of this can have secondary effects on the body. So physical therapy should focus on not only treating secondary impairments, but treating underlying pathologies to restore function and promote independence. So just a reminder that patients can have multiple diagnoses and multiple factors playing into their current situation. So really the big picture here is to treat the individual as a whole and make therapy meaningful for the patient. You want them to get back to doing what they want to do and keep them motivated, and education is super important throughout the whole time. Here are my references that I used for this presentation and for the treatment of my case study. I do think that more research is needed on Stevens-Johnson syndrome just because it's kind of new and we're learning more about it each time, but really the big takeaway is just focus on the patient's impairments and treat the person as a whole. So I hope you learned something from this presentation, and if you have any questions, please reach out to me. Thank you.